The beat that you hear right now reminds me of the beat of my heart. Bum, 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 bum. So when we're talking adrenaline rush, good or bad, maybe something that was very stressful or something that excited you, that could lead to a broken heart. We're going to talk about broken heart syndrome. More than 300 papers published in the scope and space of heart health and wellness and much more. Oh, yeah. And we're always talking about ABM, the acronym, Always Be Moving. That's coming up next with a cardiologist you don't want to miss on the Bob Jeswald Show.
Personal power, people positive, the community of connection. This is the Bob Jeswald Show.
Oh, and this week is great. We continue the conversation so many times, and we've done this before. I think it was episode 3. Dr. Hunter Champion is in the house. And, of course, Dr. Champion, we weren't going to hit it off right here today. Again, welcome, Hunter, for some great things. Broken heart syndrome.
Yes.
Which, to me, is, you would think it's a fallacy, but it's truly not, because you explored that and writing, 300 papers. I mean, at least over. I mean, it's incredible. You dive deeper in the research, and boy, does it pay off.
It does. I'll tell you, the broken heart syndrome was really something that just came out of observation. I was an intern at Johns Hopkins with my later partner, Lon Wittstein, in this project. And he was the attending in the CCU. I was the intern. And, we had a series of patients that just came in over the course of a week or two. And all of them had a similar presentation. They looked like they had a heart attack. They had chest pains. They all had clean coronaries on their catheterization. They had very weak hearts. When we then started diving into a little bit of what's been going on, they all had a emotionally traumatic experience.
Wow. And that's something where you realize, if anybody's old enough to know Debbie Reynolds, phenomenal. And I was in Las Vegas and met her a couple times. Just a wonderful lady, but she died of obviously a heart attack, or she had some illness related to that. But whether she was fighting a battle, it was her daughter, Carrie Fisher, actress, first, and you remember in even the latest Star Wars, and they even had her in the latest Star Wars after she passed, had died the next day or very soon after her mom passed. Broken heart?
Yes. We see this a lot. Actually, if you go to Mount Vernon, one of Washington's brothers, on one of the obelisks in the cemetery, it says that his wife passed away 2 days after he died of a broken heart. And, the concept of mind-body connection really goes way back. I mean, you even go back to the Bible. Job's heart felt heavy. And so really we know, and we all know that there is this connection. If we get a lot of stress, our heart starts racing. We may start feeling some chest discomfort. Some people with anxiety will get shortness of breath, that type of thing. Certainly, we want to make sure it's not the heart, but diagnosis of exclusion, it may be anxiety or something else.
So contrary to that being said, somebody being very excited, could that cause or precipitate a heart event?
Absolutely. So from our New England Journal paper in 2005, where we actually coined the phrase broken heart syndrome officially at that time, we had one of our patients actually was at her own surprise birthday party, and boy, was she surprised. 65 years old. She had seen some friends and family she hadn't seen for 20 years. She's flitting around the room. She's all excited, just reunited with all these people. And then all of a sudden, bam, she says, "Take me to the hospital." She comes in on a balloon pump, cardiac cath, cardiogenic shock, clean coronaries. And actually one of our partners there, Jeff Raid, who was one of the first people to help buy into this concept, because this was pretty, pretty controversial. He leaned down when he saw the clean coronaries. He said, "Did anything interesting happen today?" She's like, "My birthday." And so she was actually one. She was
aware enough to interject that.
Oh, absolutely.
Smart. Yeah.
She's got a balloon pump. She's got multiple pressors to try to keep her blood pressure up. And she was actually featured on our 2020 piece, Mrs. Weber. And so I still remember to this day. It's fascinating. But we've seen other happy events, reunited with a loved one. A woman who had given up her child for adoption was reunited, and bam, ended up going to the hospital. So we see this. Marriage proposals in some cases, and that kind of thing we see. So it can happen. It can happen with happy things. Vast majority, though, are more traumatic. Death of a loved one is by far and away the most common thing that we see. In this day and time, we tend to give news kind of more like social media, little quips, boom, boom, 120 characters, your mom's dead, and a telephone, that kind of thing. In the Arab culture, as we've talked about before, some cases, the physicians teams may let the family down easy. Oh, she's very, very sick. You can't see her. Oh, it's getting worse. That kind of thing. To kind of lay a little crepe, as we say, and give them a chance to kind of process that information, as opposed to we're kind of, I think in the Western world we're kind of more matter of fact and hey, she's gone or he's gone, and so that sudden emotional stress is really seemed to be what triggers it.
So be erring on the side of caution. If God forbid you were in a situation like that, you would allow. It would be a softer approach in our culture, just to pull you back over here a little bit. Don't just hit somebody hard with something right away.
I think correct. I think any kind of bad news is I think sometimes we think about being tough, and we always rip the Band-Aid off fast, that kind of thing. But really that might not necessarily be the best way to handle things, especially when you're dealing with 90% of these patients end up being postmenopausal women. And it's a very interesting cohort. We've done some behavioral analysis and some psychiatric analysis, and they tend to be the matriarch of a family. They're postmenopausal. They tend to be the person that the whole family tends to bring all their troubles to, and so they tend to be the ones. They tend to be a little bit more type A personality. They tend to be a little bit more high strung, that type of thing. They seem to be more that can happen with anybody. We see it in 18-year-old girls as well, and men. Much less common in men, though.
I'll pump women up because we know women are strong in general. They lead the way on that, but they do put on. There's a lot of pressure on their shoulders when they're doing that. I had a step grandmother. She was from Poland. She was Polish, and I grew up Italian descent neighborhood, and she was always going 100 miles an hour, taking care of her husband. She passed before him. She would sweat profusely all the time, and I'm assuming she had high blood pressure. I don't know, or something like that. I mean, she had heart issues, if I recall. So there's a lot of pressure on that. So you want to kind of mitigate that. It's always, if you see something like that, maybe intervene, go see your doc. Before we get into some questions here, because this is some great stuff. People are so excited that you're here. You get a lot of compliments locally. Everyone loves you. Southeastern Cardiology is a practice you're at. You do clinics, and clinic. When we say the term clinic here, that means you're seeing people. Correct.
Outpatients come in from in our catchment areas over to Montgomery, down to the Florida Panhandle, over to Savannah. Essentially, I since I was in academics for so long, I essentially say you come to see us, you get academic level care, but with free parking. And you can avoid Atlanta and Birmingham traffic. So
love it, and that's exactly why people love you. I think that's what it is, because your candor, you're certainly caring, and there's that's that bedside manner that people really want. Let's face it. Our doctors are part of family, the way I like to see it. Some people are like, hey, I want somebody who's black and white, but I like someone to talk to me like you do. And you do interject because you have that academia background. You do a lot of papers, and you got the PhD, and you're rocking and rolling plus MD.
Right. And I think that's a very important point. I tell patients all the time, I said, listen, I'm never going to sugarcoat anything with you. You don't travel all this way for me to sugarcoat anything. I'm going to treat you like family. But I also remind them, sometimes family, even family needs a cussing out every now and then. If you need one, I'll give it to you. Yeah. It's always done out of love. But it's at the end of the day, I think the way we handle patients is we see them as we're a team, and so I think that's the important difference in terms of how we handle things with people.
So it's a good transition then, because we had someone who has that question, and the question is this: first of all, your team. Let's talk about it. You're MD. You got somebody who's a NP or in a PA, physician's assistant, nurse practitioner. Correct. How does this all fall in line when you see a cardiologist that practices in these capacities? How does their background differ from an MD, or could they do the same, or what's the deal
Absolutely. There? So this comes up a lot because oftentimes we in the kind of the new era of medicine, we do have a team, and so I have a great team. I have a nurse practitioner, Kyle. PA, Jamie, both are outstanding. We do consider ourselves a team. We also have another nurse practitioner named Rachel who handles our heart failure clinic specifically. And so we're a team. I think a lot of times people kind of think that everybody's kind of doing everything on their own. We actually have a conference about each patient before we see them. We discuss what our plan is going to be. If this, then this. Nurse practitioners and PAs operate really very similar capacity. I'm always there to see the patients, though. I think and everybody handles their teams differently. I think I kind of get the impression some physicians kind of have the nurse practitioners and PAs go see all the patients, and they're sitting back in their office playing games or surfing the net or listening to podcasts. But I'm kind of but we're all in the trenches together. Yeah. And I do, and I start up front when I meet a new patient. I say, Kyle and Jamie, we are a team. If you talk to them, that is the same as talking to me. And certainly we have that mutual respect. And Kyle's been with us for 7 years. We're going on the 8th year together, working together. I mean, we finish, we know each other so well. We finish each other's sandwiches.
Okay. Oh, I thought you were going to say, and I thought sentences. I was going to try to finish that, but I couldn't.
but no, and I think that's an important thing, and really I think it's important too for patients when they come in to kind of find out how does the office work, and some patients really do prefer to see me, but I'd say. Actually, what's interesting is the vast majority of our patients, once they get to know Kyle and Jamie, they actually like them more than they really like me.
Well, you know what I like about this, and this is something that anyone listening should maybe consider. Find out if there is a team. To me, you're watching a football game. How many people behind the scenes, even during the Super Bowl, with the coach.
Right.
That's going on.
Right.
But you guys don't do that. You don't block your face with a piece of paper like on the big plays.
I think a lot of people would prefer that I block my face.
Yeah, I wasn't implying that.
I have a face much better suited for radio.
Well, let me tell you something. Your voice and the way you're kind of setting the tempo here is important for everybody to understand that it's good to have a team. I would want somebody operating in that because there might be one thing that they may remember from that patient.
Right.
That you didn't pick up on. Say, hey, do you remember this, Dr. Champion? She was also saying this. Well, that's weird. She forgot to tell me. Or there might be something you can fill the gaps in.
Right.
That makes sense. You're getting a full, complete picture.
Well, and for that matter, I think it's very important for a patient to figure out kind of how the actual office works. There are some offices where you don't actually have assignment with one physician. You actually, and you don't know which one you're going to see that day. It may rotate depending on who's doing what, and so that's something I think it's important that, and I tell patients all the time. I said, listen, this is like a first date. If you don't like my approach or how we do things, then I'll probably go sulk for a little while, but I'll eventually get over it. And it's important that you feel comfortable with whomever you're working.
Yeah, and I agree. There's so much competition. That's why I still think the way our healthcare system, in my opinion, is important, because then you do have that freedom. It's like choosing a cable company. You only have one to choose from. You're in trouble.
Absolutely.
But if you got one healthcare system, I tell this to people all the time, it's not fun. Talk to my friends in Canada who they needed a cardiologist and they're waiting in line a long time. Right. And of course now we're in that post era of COVID, and there's surgeries that haven't been done. I mean, critical surgeries.
Sure.
Cancer patients that need something. I talked to a nurse recently, and she said, Bob, it's not so much that the beds are crowded from COVID. She said it's because we're trying to play catch up. We're exhausted.
Yes.
And there are people that have stage 3 ovarian cancer should have been in here like 6 months ago, and they're just coming in. So there's some scary things there. So I'm going to shift gears, and I'm going to ask a question here for one of our guests or somebody who's listening here tonight. But the COVID, getting back to that, we're trying to figure out, and I'm sure you are there any papers being done? Are they exploring what could happen after those who had COVID? What's the ramifications? What happens to the heart? Is there anything you're concerned about?
Absolutely. I mean, we're seeing this, and obviously this is on the job learning. In fact, we now have post-COVID long haul clinics that are coming up. There's a few in Atlanta. Piedmont, Emory have them, really primarily for research to try to figure out. I've got one of my friends from Athens, Georgia, avid runner. I think he's probably in his mid-late 40s. He's had 5 bouts of pericarditis in the post-COVID time. Otherwise healthy. Myocarditis, obviously, we see. What we really see a lot of, though, and I think what we're seeing more than anything is a lot of arrhythmia. So it seems to be more of a cardioneural or neurocardiology type of phenomenon. A lot of palpitations, a lot of palpitations that happen when you stand up, maybe dizziness, those types of things. And we still really just don't know anything about this. I have some patients who have a problem with it for a month and it goes away. I've got a few patients that now they're on their second year of dealing with this.
Pericarditis temporary, which is an inflammatory response in the heart, which are typical in kind of virus, or if you're doing like some kind of vaccine or something, when we do get vaccines or shots, they sometimes cause an inflammatory response. And I've heard this, is that true? Or is that
absolutely?
Okay.
And so you can get an inflammatory response, and the myocarditis is the inflammation of the muscle itself, of the walls of the heart. The pericardium is the sac in which the heart sits. And normally there's a certain amount of fluid that lubricates the heart beating in that sac. When that gets inflamed, you can sometimes get additional fluid and the inflammation. But you're exactly right. And when we do vaccinate, we're trying to build an immune response. We're trying to have some inflammation there to kind of build that immune response. But especially younger people tend to have more problems. You don't really hear oftentimes about older people getting myocarditis as much as you do young people.
Because younger are more active?
Well, I think their immune system's just stronger.
Okay.
I mean, and so it's more active and exactly. So they Coxsackie virus. I mean, kind of classically in the heart failure clinic, if we see pericarditis or myocarditis, we're thinking, kind of a young person. Young males tend to have myocarditis more often than young females. Pericarditis can be any age, though.
Long-term effects. Could we be setting ourselves up for a cardiac event, something bad as later in life, or is this just something that'll pass, strengthen, or
in
go
the
away?
majority of people, it ends up being kind of a one-time thing. You get over the inflammation. We use anti-inflammatories oftentimes for a period of time, but there are people who have to go to transplant, and so you can have myocarditis that does go to transplant and that type of thing. So you can have long-term ramifications. Generally, it tends to be self-limiting though, and you tend to see the heart function come back, over a period of time.
All right. Well, I got somebody here. Lori, she totally agrees with a lot of this. She goes, I am very interested in, as we were talking about the broken heart issue, because she's curious to know more about it. We did touch on it a little bit, but she did want to know whether or not, is this something that could it happen to everybody or to some degree? Mm-hmm. I mean, that would be the question. Like when you do lose someone, you notice that people's health sometimes declines a little bit. They may come back. Some people don't. Mm-hmm. Is there some kind of, some kind of event? How about I say that in the heart with anybody who goes through a shock like that? Even if they seem to be healthy and they never die or get a heart attack.
Right. Well, you got to remember the broken heart syndrome people that we have seen are the far extreme, right? Okay. They were bad enough. They had symptoms of heart attack. They went in, they got a heart catheterization. You can have ST elevations, which is the immediate, that's where you kind of roll in like an ER and you go straight to the cath lab type of thing. But I do think that there's probably a range, and we had one patient who a relative had passed, and they went and just stayed in their room for 2 or 3 days. They were probably just getting over that. The classic features of the broken heart syndrome, though, or stress cardiomyopathy, is really a sudden event that then precipitates a symptom associated with chest pain or shortness of breath, similar to a heart attack, but has no significant coronary disease, and then has a weakness of the heart. And so we see different types of that. But I mean, we see people whose ejection fractions, which normally should be 50, 60%, go down to 10%.
Oh, yeah.
Now, the good news, though, there is that they tend to get better over a very short period of time. So we see sometimes over 3 or 4 days, their heart function can revert to complete normal.
What's the period of time in this? And this is good clarification because you're already talking to somebody who's predisposed, perhaps, that would have a bigger impact for Miss Lori here of a cardiac event. But think about this. If that's the case, what are we talking about the period? How do you get them in to study them real quick? Do you know, I mean, you kind of hear through the grapevine, hey, Joe, we know that his wife, just passed. Let's bring him in, Joe, set him in front of a thing and start monitoring him? Or is this really, I'm being facetious a bit, but how do you do that?
I'll tell you how it happens. I mean, how we developed this huge database was essentially people come in with heart attack symptoms. They can have ST elevations. They go straight to the cath lab. They can leak heart enzyme like a regular heart attack. Okay. They go into the cath lab. And then when we hit them, with the dye to look to see if there's any blockage, what we see is a weakness of the heart immediately, but then we see clean coronaries. Oh, and I think that's an important point, because when we were at Hopkins, Lon and I were kind of after the second or third year. I mean, we had not even published this yet in the New England Journal, and all of the interns and residents are so comfortable with it, like, oh yeah, this is just broken heart syndrome. No need to cath that person. I said, whoa, guys, this is a heart attack until you prove that it's stress cardiomyopathy.
Taking it from a scientific point of view. Exactly. I mean, you're not just arbitrarily. You got a thesis here, but we're like, okay, but let's prove this thing. So we got to look at it,
correct,
and make sure all the I's are dotted, T's are crossed before we just make that assumption.
Correct. And then, like I said, what it usually boils down to is when you see that classic pattern, the classic heart shape and the function, lack of function, the clean coronaries. Then that's when the cath lab guy leans down and says, "Hey, anything funny happened today or interesting happened today?"
Yeah. See, there you go. I mean, that is remarkable. Out of your papers that you had, though, with that study, to me is profound. What's your next one that you're proud of, or thought, you know what, this paper here, it was just what I always thought or suspected, or vice versa? If you did something and say, oh my gosh, I was wrong, we were able to find out this is what happened.
Well, the one thing in science and publications is it's kind of like a gambler or a stock market person. You never really hear about the losses. People say, oh, he published 300 papers. Every study worked for him. For those 300 papers, I have 500 studies that ended up not working out at all.
Yeah, you got to think of that. So exactly. We're talking about how many total, double, triple what you just,
Exactly. But I'll tell you, in the 2000s, we had a really really good run. I mean, we had the broken heart syndrome paper, and New England Journal wasn't stupid. They published it 4 days before Valentine's Day, and
good marketing.
Exactly.
Smart, yeah.
And that's really where, I mean, it got picked up by thousands of, Associated Press, NPR, the whole nine. But then, we also had some other really good studies as well. We were really the first to show that PDE5 inhibitors like Viagra and Cialis can help improve lung function, and now that's FDA approved for pulmonary hypertension. We were first to show that it was able to help repair heart failure, those types of things. So, like I said, we've had a good run.
I'd say so, and the more the merrier. Any more coming our way, or do we need to watch for? Or
well,
are you
interestingly enough, we actually just got a really large grant through the NIH, which is really interesting. We're using a STEP test, which is a gas exchange test to be able to we use for elite athletes and for average people to kind of differentiate shortness of breath. So we're able to tell with this very simple 5-minute test what part of shortness of breath is from the heart, what part is from the lungs, what part is from how the heart and lungs are working together, what part of it is just conditioning, are you just woefully out of shape? But we get objective data. And what we're able to do is use a non-invasive test in order to try to predict what part of this may be fluid overload, what part may be something called pulmonary hypertension or high blood pressure in the lungs.
Well, I'm interested in that because having a runner's asthma sort of thing, and I can't tell. I think there was one point where I can't tell, do I need a stress test? Because, I don't know if this is more lung inflammation or is this heart or both or one or the other. Right. So this test can actually do this with this NIH.
Absolutely. And so what this was able to do, we use it clinically. It's FDA approved. So we do this every day in the office. We run about 15 through a day. But it does. It really gives you some good objective evidence, and it really helps us be able to tell patients, should you limit yourself? Should you not? Is your workout schedule working well for you? We can test people before cardiac rehab and after cardiac rehab.
Is there any benefit to do this with no issues, but to come in and say, look, I want to make sure I don't have something going on?
Well, typically with cardiac testing and with insurance, obviously, you can't get through anything without insurance. Typically, they only like to test people that are having symptoms. But, that said, if you've got any type of limitation, if you feel fatigued, if you feel chest pain, any type of shortness of breath, this helps you kind of, because a lot of times our patients will say, Dr. Champion, I'm excited to go exercise and I'm willing to walk down the road, but how do I know I'm going to make it back?
Yeah, that's a good point.
It's not a bad point. And so this really allows them it gives them a lot of confidence to know. Say, hey, you're not going to hurt yourself, or you're just woefully out of shape. If you get hot and sweaty, you're going to stop and rest, take a break, get your wind back, and then get back after it.
And your acronym that you come up with, ABM, which I love, always be moving. I always say, just don't be sedentary. But would that be? We're not going to classify that as you're going to walk down the road and not come back. You're saying when you say ABM, you're saying what?
Just move. It's amazing. We have people. It's interesting. Because oftentimes I'll tell patients, I say, we really need to get you on a decent exercise program. And they're like, the first thing that says, oh, my back, oh, my knee, that kind of thing. I said, well, there's a lot of things we can do around that for people who have knee problems. Do something that's less forceful on the legs, like running. I mean, think about the elliptical. Think about the recumbent bike. Think about rowing. The warm water aerobics at the YMCA is absolutely fantastic. It takes a lot of pressure off the joints. A lot of these patients are kind of like otters. If you see an otter on the land, you're like, goodness gracious, they look terrible. But they get in the water and they're actually halfway graceful. And so should
we say that to somebody if I see someone?
I generally don't do that.
Maybe I should avoid that.
Exactly. But the warm water aerobics is amazing. I mean, it's like a club, and they play music, and it actually looks a lot of fun.
It does, and they play some good music. I heard some rock music one day when I was out there, so I said they're really jamming the tunes. And this would be classic rock, so it'd be our age group and above. And so these
I was still
late 60s, early 70s.
Yeah, I've got nothing wrong with that. But I mean, certainly, I think you could put some TLC, maybe play some No Scrubs or Waterfalls,
look at you,
things like that. I do actually for karaoke. I do a medley of that. It really brings the house down. Brings tears to the eyes.
Well, let's hear one.
Well, not right now.
Could you cue it up, Dylan? cue up the music. I could do some Earth, Wind, and Fire with you.
There you go. Okay, fair enough.
In the Stone is one of my favorite songs too. You
Yes.
know, man, it's very, very filled. You could feel it in your heart like that. But you think of Psalms too, and about you use biblical references with Job and a heavy heart. You know that of course the psalmists and King David probably sing most of those. Singing a song makes you feel good. Is that something that helps the heart?
Absolutely. Well, I'm a big believer in this day and time, everything is just so so rapid, right? Remember when the news was Walter Cronkite or Dan Rather, single face in the TV screen with a still picture in the back.
Sure.
Now you get information overload. I mean, you've got runners everywhere. Someone may text me, if I don't call back in 5 minutes, they're calling. You don't really get downtime anymore. So I'm a huge believer in finding that downtime. And for some people, it's meditation. I'm a big believer in meditation. We could have a whole show on that.
Great. Yeah.
For some people, exercise is meditation. For others, prayer is great meditation.
I agree.
And focus on that. Focus on your breathing. There are great apps that you can use. But we've had very good success in terms of being able to potentially bring down blood pressure medications, anxiety medicines, bring those down just by adding meditation and exercise. Yoga is also great.
You said meditation, a whole show on meditation. How would it go? Something like this?
It would be 2 full hours of just you and me breathing into the mic.
Inhale.
Yes.
Exhale.
Maybe add a little ohm in there.
Got to be careful how I do that. Now, that's another show for another time.
Absolutely.
As you would say. That's another show, Bobby J, for another time.
Exactly.
I got you. No, I like that. But and I make fun of that, but that's true. People really, it's funny how that makes a difference. And we are at the mercy of technology, and I'm constantly getting pinged, dinged, bad weather walking in. Everybody wants a custom forecast because they're not patient enough to wait on TV, or they don't look deep enough on their app or look at my reports that are in the app. They want to hear it specifically from me when they want it on demand. I'm the reason why I probably get a lot of that. I set the bar real high in that area for my own self, so I can't even back off of it because then these people are relying on you, and then so you do it in a way where I cut and paste now. Like I know this is going to be the common question asked, so I cut and paste it, and I keep pasting in my text. And I'm not saying I don't want people to do this, but it is a world of demand, and I can imagine even the medical field too. It's a right now. I want it now. I need gratification now. I need to know my answer now. And and as soon as I feel something, I want it now.
Yes, and absolutely. And so that's part of the, I probably say no fewer than 15 times in a day, expectation management.
Yeah.
If you learn not to expect too darn much, you're not going to be disappointed. But also too, we see patients all the time. We need to get set up for a stress test. Well, the stress test may take a week or two to get scheduled. It may take even longer depending on how busy we are. People come in and complain about parking. I say, well, if you go to a restaurant, you're not going to eat at a restaurant that doesn't have anybody in the parking lot. And I said, you want to come to the popular cardiologist?
Well, and I heard Bishop Barron in a recent podcast, this is so funny, who said this today, and this is biblical reference, and I won't quote it completely, but the bottom line is, if you think about this, if you give a gift. I give a gift to you. You're my friend. Of course, by me doing that, and some philosophers and other folks that would look into this deeply would think, well, Bob, he likes you. Of course, he's going to say thank you, and that's what you want to hear because deep down, you're giving that gift to get something in response. Whether it's as simple as that or something as, well, if I gave it to him down the road, Dr. Champion, when my turns, he's going to cash me in with a little gift or something. But if you give it to an enemy, and you're not expecting, going back to the expectation thing, that enemy is an enemy for one reason. They don't like you, so they will not thank you, and they will probably not give you anything back. That's why your enemies, as Christ would say, make sure, love your enemies, the ones who don't like you, give it, show them love. The ones that, whatever, hate you or whatever, or just against you, show them love. Keep doing that because you're not expecting that expectation back, which makes you in a position of where, okay, the expectations in the bar. It makes sense. How philosophical you can get on that and going in the past versus the new, why not?
Right.
It's like these are the things that some of the stress loads get. People who chronically complain, always got an ailment, got something. I come from a family so I'm very, Mom's going to listen to us. She is listening to us, but she's good. But you coined the phrase, hey, look, you're Bob, you're a hypochondriac. My wife calls me that. I'm not a hypochondriac. Am I? Because I say that. No, I identify a problem. If I fell, my body's like the engine of my car. If I hear something ticking a weird way or something else, I'm jumping out. I'm proactive. It's like I like to say. I'm not calling off from work. I'm not saying I can't get out of bed because of my, this hurts and that aches and this and that and the other. A lot of it's psychological. How much of your patients coming? How do you think is psychological? And am I being a tough guy, or should we, or and define hypochondria as?
Well, I think part of this it boils down to, I tell people all the time, you know your body better than anyone. And so if there is something going on, whether it's real or perceived, let's work it up. Let's at least make sure. And I think in some cases people do kind of get labeled as hypochondriac, and then nothing gets done. They don't ever get validation. Well, nobody did an echo on me, nobody did a stress test, nobody did this. How do I know it's not my heart? And so that's why, I'm as part of that team, we believe in I take you seriously. You come in. If we find something, let's deal with it. If we don't find anything, then at least we feel good about that and say, hey, let's look at something else. As we said before, the diagnosis, stress and anxiety, it can cause chest pain, shortness of breath, palpitations, a lot of things, but that's the diagnosis of exclusion. We do not have an actual test for stress.
Okay.
Actually, I was at a talk last night that was really interesting, given by one of the heads of preventative medicine at Piedmont in Atlanta at the mothership up there, and some new data showed that stress is a major factor in the heart, and that women who have significant amount of stress, that's the equivalent of smoking 3.3 packs of cigarettes a day.
That's insane.
So stress is just as bad, and we're just now learning about all this other stuff. In terms of in the workplace, sitting is the new smoking, and so there's a lot of things that your increased risk of heart problems by just sitting all sedentary job, that type of thing.
Somebody who's exploding all the time, or very quick tempered, or somebody who's like a ticking time bomb kind of thing, because they're ready every time they shoot off at you. They're loose cannon or whatever. Is that better to be that way, or we're hard on your sleeve? I have to use that reference,
right?
Opposed to holding it in.
So it's a great point, and I think a couple things there. I do think that there are some people. Me personally, I think it's probably better for your overall body rather than kind of internalizing it. We always talk about, like, why don't you just put all that emotion into a little ball and push it way down deep? Well, you may push it way down deep, but eventually it's going to blow up. I have a very long fuse, and so but if I get pushed too hard, you don't know what you're going to get.
Yeah.
Right. But so I think in some
you said that with a smile on your face. You like how you smile like that, Dylan? You did that, and your eyes just kind of get that.
Exactly. But I think there are some people though that are able to just say, hey, I'm going to blow up. I'm going to just shoot off all that steam, and you know what? I'm fine now. Mm-hmm. You just give me a chance to blow off this steam, and then I'm calm. I think that's probably worse for you to kind of just hold on to this and harbor all this emotion and everything, and just say well, it's going to go away as eventually.
But I want to be clear: if you're in a car and there's a moment out there, somebody cuts you off, you may want to resist, because nowadays you may get shot at.
Oh, so absolutely.
Yeah, so in that case, you can hold it in, and then or scream to yourself in the car or something like that. Why, you no good son of a gun? I don't want to do that. But you don't want to get into a situation where you keep it in control.
Right. Well, and I think, nowadays too, with social media, I mean, if you have a beef with something, you can just pop off. And so I like that old philosophy of, hey, write everything out, write all the nasty stuff you wanted to say to that person and put it in a drawer, or I guess nowadays we put it in a file folder on your desktop. Yeah. And then come back to it 24 hours later and see if you really want to send that.
Yeah. You know what? Good point. And I agree with that. I had to take that lesson a few times. I would shoot off emails and say, why did I just say that? Could I get that email back? And sometimes you can't, you just can't. And that's sometimes you can if you're lucky. Well, I got something. Miss Jeannie writes, okay? She says, I'd like to know, once a person has open heart surgery plus stents, I think she meant, stents, and a pacemaker and defibrillator, do they have restrictions for the rest of their life, or does this mean that their life goes back to normal?
So there's a lot packed in that one question. So the answer is there is a huge continuum on this. We have people that that need open heart surgery or stents. Once we get through that, we put them into cardiac rehab. You can go back to a normal life in that regard. I think the key thing though is that, and this is another thing I always say, the only place in the world where success comes before work is in the dictionary. If you want to get success, you've got to put the work in. And so I think that's a big thing as well. Now, oftentimes you're stuck with medicines, moving forward. If you have a defibrillator, you probably have a weak heart, that kind of thing. So there's probably some restrictions down the road. But we have people with low ejection fractions, weakness of the heart, that they're running marathons and that type of thing. I think, I try to tell people, don't let some of these numbers define who you are. I think sometimes people can kind of push themselves to be a cardiac cripple, and it's more in the head than it actually is in the body. And that's why I really am a huge believer.
So I'm getting back to that mental thing.
Absolutely.
Yeah.
And, we've got a wonderful cardiac rehab here in Columbus that is outstanding. We send most all of our patients that have a stent or bypass surgery there, because if you think about coronary disease, it's not something generally that just pops up. It's something that's been brewing for years and years. And so oftentimes patients kind of start ratcheting back. I'm just getting older. I've gained some weight. I'm getting more short of breath, but they kind of rationalize it. And so now you're actually getting blood to areas that weren't getting blood. And so now you have to build your strength back up.
So don't discount those people you may think, okay, a lot of this is psychological. Yeah. There's some validity to that, and we need to watch it too. She mentioned defibrillator. I think of the AED, your heart's going through defibrillation or something. You got to sometime put that AED in. Is she talking about that, or a pacemaker? Is that something that is like a pacemaker, or is it?
So the E of AED is external.
External.
And so you put it on, and it will actually check your EKG, and it will tell you to defibrillate if necessary.
Okay. Stand back.
Exactly.
Stand back. Do compressions. Yeah.
Exactly.
Yeah.
I tried out for that voiceover, but I didn't.
Could you imagine having the voice of the AED machine?
Yeah.
Well, it's like having the voice in the airport. The lady, please check your bags.
Exactly.
Yeah.
But the defibrillator that she's probably talking about is the internal, the implanted defibrillator, and that's really kind of like a watchdog. It's watching for a bad rhythm. The beauty of the new defibrillators, though, is they don't have to just shock you. So if you're going into a bad rhythm, they'll try to pace you out of it. They go through 4 different mode switches to try to get you out of it before actually having to discharge the big shock.
I've experienced one of those in my life. I was actually at the Y locally here, and I was with Fred. I mean, Fred handled it really well, but we both worked right away. We saw a guy. He obviously was having a heart attack, or he had an aneurysm. God only knew. But when we hooked that device up, it was amazing. It told us everything we needed to know. Kept him alive until the folks got there, but unfortunately passed later that day. Right. But he had recently had I think open heart surgery or something. He was in the gym, but it was sobering to see that. But it's amazing technology, as you said, and so that makes sense. Thanks for that clarification. Miss Dorothy asks this. Miss Dorothy says, my mother had died. This is interesting. I did not know that. I just happened to know this person. My mother died from heart issues attributed to broken heart syndrome. Wow. Within a few months of her father's death. Now, this is months after. We had never heard of this syndrome, and I'd love to hear some advice for families, children, when dealing with a grieving parent, because that's a great question, Dorothy, because in that case, this is not right away. So what would we do in a situation like that? Is there any coaching? Is there anything maybe we can prep people that might have an issue or may not, that may want to know?
Right. So I think the key thing there is really, when we have patients, and it really is case by case, because every personality is different. I think it's incumbent upon really the family to figure out what is going to be the best way to handle this. I think the key thing is showing love. There really is no right or wrong way to grieve. I mean, certainly grieving can go bad and it can last a prolonged period of time. But I think certainly everybody is different. I'm a big believer in counseling. Some people do really well talking to somebody that doesn't have a horse in the race and just kind of getting things out. For some people, medication can be very helpful. I think the key thing though is just being there for someone. And so, certainly we see this, and broken heart syndrome can be deadly. I mean, if you make it to the hospital and everything, you've got a great chance of leaving. But certainly we can see this. We see greater risk of arrhythmias. We see greater risk of blood clots and stroke after broken heart syndrome. Wow. Just because all that adrenaline makes you more prone to clotting blood. And so
I never knew that. Yep. So that kind of different from the adrenaline rush of something that's just exhilarating because you're at a concert. Would it? Or could it be the same thing?
Same thing.
That's it. That's because you did say that earlier. I remember you did say, because you can be in a happy situation like the surprise birthday party.
Right.
So that's good. I want to make that distinction. So adrenaline, good, bad, or ugly, in between, could still have that same impact.
So during my time in New Orleans, during medical school, we after our big tests in classes, we'd all go to Bayous. We'd go to Bayou St. Louis or go to Biloxi and go to the casinos. And I've seen it both ways. I've seen people collapse because they had a great run at the craps table. I've seen people collapse because they just had their last dollar that they lost in the slot machine. And so it happens for both. But the adrenaline is the same.
Interesting.
And that's really why, medicines like beta blockers can help protect heart attack, because what it does is it tempers the effect of the adrenaline on the heart. That's why, people who have anxiety, but also people who have a lot of stress, the beta blockers, metoprolol, things like that, they kind of block the receptors that the adrenaline hits on the heart. So it prevents some of the palpitations and the racing heartbeats that come with that.
Metropo, I don't want to get too deep into this, but an alpha and a beta, are they two different ones?
Two different ones.
Okay.
Alpha tends to be more vasoconstrictor. It has other effects, but the beta receptors tend to be in the lungs. So like when you take an inhaler, that's usually hitting the beta receptors to open up the lungs.
Good to know. Okay.
But the reason why a lot of people get a racing heart after they do that inhaler is because they hit the beta 1 receptors in the heart.
That's why it says sometimes it gives you a feeling of caffeine or drinking like 3 cups of coffee. I would do that before the Soldier Marathon because I was having the runner's asthma. And I remember I did 2 puffs back to back with albuterol, I guess, in that sense. And boy, I got like really, I felt, I got like a head rush like there was no tomorrow. I had to put my head between my legs for a second. Everyone's like, "You all right, man?" I go, no, I'm okay. I think it's from when I just inhaled here. So I didn't inhale, but I did not inhale. But in that case, I did. But so no, that's we got another one. Mr. Bryce asked this question: what are some natural ways someone can reduce inflammation, specifically as you just kind of touched on a little bit, related to the heart, like cardiac sclerosis, I think is what it meant to say there. Yeah.
So inflammation is a major player in this. You know, we've got measurements like highly sensitive C-reactive protein that we can measure. If your level under normal circumstances is elevated, you're going to be at a higher risk down the road of having a coronary issue. A lot of the medicines are anti-inflammatory. We know that the statin medications that we take for cholesterol lowering have anti-inflammatory. Aspirin has anti-inflammatory activity. So aspirin works from a number of different ways. It has anti-inflammatory activity. It also inhibits the platelets from clumping up that can cause mini strokes and also heart attacks. Then there's some more natural ways that we can do that. We have to be a little careful just because a lot of the nutraceuticals are not regulated, and you just want to make sure that you talk to your healthcare providers about whatever you may be taking, because in some cases they may have liver implications. They may interfere with some of the metabolism of your other prescription medications. You know, a lot of people take vitamin C for its anti-inflammatory activity. But then you have some other things like echinacea. There are various things. I mean, you know, a lot of things actually were born out of natural, things. One of the things that we've been working on, we talked about before, is lowering blood pressure with beets. So beetroot juice and beets, super beets, you see this advertised. We've had very good success with some of our patients in lowering their blood pressure just with that. Maybe stave off additional medicine.
Is there too much anti-inflammatory? Because see, I do fish oil.
Yep.
And I feel like this is where a lot of times people are like, how do I do it? Because I think a lot of these natural anti-inflammatory, even some beet powder. I do turmeric.
Yep.
I do, what else would be anti-inflammatory? Vitamin C, as you said. I do quercetin with my zinc.
Right.
But am I on the right path here? Is there something that's too much, or could you get too much anti-inflammatories? But these are different natural anti-inflammatories.
I doubt you can get too much. I think, we always joke, because I take a fair number of vitamin supplements myself, and I bring them in a Ziploc bag, and I refer to it as my vitamin, in the singular. And my dad and I always joke that we may just be ending up with brightly colored and expensive urine, but we're not taking any chances.
That means you're passing it's waste. I mean, it's stuff that's it's not retained. It's going through and you're peeing it out.
And that's a very important point, because there are certain vitamins that are water soluble, and generally your body will get rid of those, get rid of the excess. Certain vitamins, though, are fat soluble, like vitamin D. You can actually overdose on vitamin D.
Okay, that's a great point, because with this whole post-COVID,
yes,
how much is too much?
So really need to have levels checked, just because different body sizes, body types, that type of thing. In general, I think a lot of people have been taking 5,000 units kind of every other day. Some people take 50,000 units a week, things like that. It depends on if your vitamin D is low to begin with.
So we need to find that out.
Yeah. Well, we know that people who are vitamin D deficient actually have worse outcomes with COVID infection. So that's why I'm a big believer in making sure and realistically speaking, we spend so much more of our time inside. So we don't get that vitamin D conversion with the sun like we used to. And so by being able to do that is actually really important.
Less sun, less angle of the sun in the winter months, of course, a lot of times too. I have drops. So if we're doing like what it recommends, like 1,000, like one drop would be 1,000 IUs of vitamin D. If you do 2, 3, what would be the symptom if you had too much vitamin D?
Well, you get hypervitaminosis, as they call it, and usually they tend to be vague symptoms like GI symptoms and things like that. That's why really what I think the smart move is, if you're going to supplement and that type of thing, do it for a few months. Have your primary care physician check your vitamin D level, and then you kind of know where you are.
That's good to know. And speaking about GI, that could be somebody could be, what the GI would maybe too much gas or diarrhea or something
cramping,
like that. Cramping or something
exactly.
like that. Okay, well, that's good to know. That's good to know. So we'll, think about that the next time. It's good to do them, but the water soluble are the ones that are probably less likely to cause any long-term effects.
Correct.
Like vitamin B, I think is a water
absolutely.
soluble. Yeah.
And again, I think the key thing there is talk it over with your care providers. Make sure there's not any contraindications for you with anything else that you're taking, and also too, I think, go within some of the guidelines in terms of average. I think sometimes people kind of get caught up in this idea, I'm going to take 30,000 times the recommended daily dose.
Hello, no, we don't want to do that.
And that type of thing. I do subscribe at least a little bit to the idea that anything worth doing is worth overdoing, but not to a huge degree.
Gotcha. That's really good to hear. So get together with your doctor, in other words, and before you try to do some of these.
Or your nurse practitioner, NPA.
Yeah, there you go. Nice little shout out to Kyle, and who was the other one?
Jamie.
Jamie too. Okay, wonderful. So we are looking down the road. We talked about COVID. You're looking at some papers, looking at the step that you guys are doing to challenge whether or not we could tell lung or heart kind of issue that's causing maybe shortness of breath or whatever it may be. Where are we? You hear of heart health. We hear about the American Heart Association. We do a lot every year nationally. I've been involved in it. It's still involved in it. You are. It's always a lot of fun. Through education is key. Knowing the reps. The song "Staying Alive." Don't worry about just do compressions to save a life, but don't have to necessarily do mouth to mouth. Right. But just do one. Staying alive. Staying alive. Here we go. Come on, sing it with me. Staying alive. What is it? This is karaoke. Come on.
Yes.
You didn't know I was going to trick you into that. But that would be, I'm making you blush.
A little bit.
Am I making Dr. Champion blush? Wow.
It takes a lot.
That takes a lot. I finally seen it. Now, I've never seen you blush, so that's really good. Is it because you're blushing or how bad it was, or is it just because you're like feeling sorry for me?
I just really feel bad for you
that's
on that rendition.
Okay.
I don't want to be associated with that.
I hear you.
And when I blush, it's a little bit more impressive because I've gone from a forehead to an 8-head here in the last decade.
I love it. So where are we with that? Is there ever such thing of having too much education, or are we overboard with this, or is it like, come on, are we making any strides here?
I tell you, I think there's a couple of things there, and I think that at the end of the day, education is critical. But I also think that one of the things that I also try to preach a lot of is a little bit like the Serenity Prayer. Let's work on the things that we have the power to control. Try not to worry about the things that you can't control, and then have the grace to know the difference. And so I think the key thing there is really, know your body. Living in a state of denial is not going to help anybody. If you live in the outer sides of Cairo in a state of denial, you're going to be in trouble. Listen to your body. If you think that if your loved one is in denial, get them to their doctor, get them to their care provider, and work it up. 9 times out of 10, I think if we catch things early enough, it's always better. That's why prevention is so much better than trying to come in after the fact. One of the statistics that has not changed in cardiology in 150 years is the fact that 30% of people who have a heart attack never make it to the hospital. Yeah. And actually, a lot of those people, if you go back and look, they were having symptoms. They were having something going on. It's just they were ignoring them. So I think the key thing there is work on the things that you have the power to control, the simple things: blood pressure, stress, exercise, cholesterol, those types of things. Because I think a lot of times people kind of get caught up in the latest and greatest thing. I'm going to get genetic testing for this, and at the end of the day, they're sitting there rocking a blood pressure of 200 over 111,
That's scary,
and yet they're worried about the most esoteric test you can possibly run. But then also too, looking at basic testing. I think we've actually got very good testing, and certainly we do this in a stepwise manner. You start off with more low level things, and then imaging. We can do cardiac CT, do a calcium score if someone's low risk, but we're trying to determine, hey, how aggressive should we be with their cholesterol? We have stress testing, those types of things.
Here's something here. I wanted to ask you this one here too, because I'm trying to get some questions and people's ideas of certain things. There's races. There's people that kind of help out. Here's one. It was called you ever hear of the Broken Heart Challenge? It was in Montgomery to Baptist. It was called it's called the Broken Heart Challenge. It's been 2 years, I think, probably because of COVID and stuff like that. To do something like these kind of races and stuff like that, is it something you usually try to get behind?
Absolutely.
Is this something, because you're tying in, to me, if you're tying in some kind of physical fitness, at the same time some awareness?
Absolutely. Well, and I think it's also too, I think it's actually really good to get out there and see. I think sometimes people kind of get stuck in their own skin, and they're kind of saying, oh, well, gosh, I don't want to do that. Go back to the water aerobics. so many people that I talked about water aerobics, it's just like first day of first grade. I'm not going to know anybody. I'm going to know too many people. I don't want anybody to see me in a swimsuit.
Yeah.
And 9 times out of 10, though, they love it so much, it's hard to get them out, just like first grade. They don't want to go home.
No, right. Yeah.
And so, but I do. I think the awareness is key. I think starting in the home is key. I think, I'm fascinated about how much education our kids get. Both my younger 2 kids are in school, and they'll come back and ask me about a cardiac issue. I'm like, well, that's kind of interesting. And they say, we talked about this today in class. So I think that's a good way to start. Heart healthy does start young.
Mm-hmm. And get them active.
Yeah.
Always be moving.
ABM, always be moving. And also,
playground, anything.
And I hate the fact that a lot of places PE is going away.
Yeah, that's that to me. Why would you do that?
Right.
It makes no sense.
Right. And then also too, reminding, we have a lot of young people who do great team sports, football, basketball, that kind of thing, but then they go to college and all that goes away. And so I think in our family, it's very important that you have team sports, but that you also have an individual sport that you do, so that you can do that for your lifetime, whether it's tennis or golf, pickleball, whatever.
Yeah.
But no, I think getting behind those is actually really important. And also too, just, at every level, I think it's important to just reinforce that, the blood pressure, cholesterol, all those kind of things.
Any kind of exercise is the best exercise too, from what your research or anything. Is resistance better than, let's just say, doing a cardio workout, or is sometimes you both combined, or do a little every other day?
I'm a big believer in combining things, just because, just for a couple of main reasons. One, boredom.
Okay.
For me, cardio is just incredibly boring. And actually, when I was in Pittsburgh, I started on my treadmill, and I lost some weight, and then it plateaued. And so I said, well, I guess I'm not going long enough. So I stayed at the same speed, but I went longer. I even made a desk for my my treadmill, so I could answer emails, because I was on this thing for so long. Oh. So I was going for like an hour and a half, a day on this treadmill at a regular pace. And I realized I wasn't getting any more benefit. So really, I get more benefit by getting on a treadmill 3 minutes at a good pace, and then go full blast for a full minute, and then come back and do like a HIIT training.
Okay, gotcha.
And the kind of the analogy I use, I think our bodies are like a lazy teenager. They're only going to do what you make them do. And so they will only adapt if you really put the pressure on. And so by and a lot of people kind of preach muscle confusion. Mm-hmm. So if you come, I tell people,
because you get better strength, and
absolutely,
development. You'll see that.
You'll see those gains. But then also too, you can also do this in the weight room. And so I'm a big believer too in speed weights. So you go do bench press, and then as soon as you finish with that set, go do legs, and then, because while your upper body's resting, you're working your lower body. And if you do that the right way, you can get your heart rate up to the 120s, 130s. You can actually turn weightlifting and the circuit training into a cardio workout.
Age and heart rate. I understand, obviously, if your heart's not in good shape, and I've learned this a little bit from cardiologists with you. I think it was Dr. Dira was in there one time, yep. And he was looking at my thing. My heart rate goes up high, but as soon as I stop exercising, I notice it drops fast. It's something that I learned, and correct me if I'm wrong, that helps it. You got a healthy heart. You don't want that to be accelerated to, even when you stop. If it's like 30 minutes later and you still got that 170 beat per minute, it's like, holy crap, what's going on? The
other thing that's also important to remember too is when you are deconditioned, and this happens, and really you can get deconditioned in a very short period of time. They did a study in the 70s. They put high school football players in bed for 1 week. Not sick at all now. They were just in bed. They were incredibly deconditioned after that week. And these are healthy people. Imagine what it's like. So I tell people, if you're in the hospital bed for every day you're in the hospital bed, the average person, it's going to take 3 to 4 weeks to get back to your previous strength. So if you're in the hospital for a week, it's going to take, 21 weeks to get back to where you,
how quick the body's memory, it'll come back, but like you said, how fast you can lose it.
Well, muscle's like a good reputation. It takes a long time to build it, but you can just lose it instantly.
Lose it like that. Right? Yeah, that's something. Yeah, that's crazy. So we got to keep that moving a little bit.
Yes.
I notice that even when I sleep, we do have these watches now, and they can sometimes tell you what your SpO2, your oxygen levels are.
Right.
And at the same time, I notice during COVID, I was always like, this one a good day for me is 97%. It stays at 97. It seems very regular. Some days will go 95. Had COVID, it went down to 91. I got a little nervous. And I know that's not like deadly, go to the hospital, ventilate them, but I don't mean to make light of that, but it's just, I can tell there was some change. So there's some benefit to that. Also, my heart rate, the more cardio I do notice it dropping precipitously. I mean,
Sure.
at night it could get into the 40s. When I'm sleeping, I can track what I did, and when I have an awake moment, it bounces up to 60. Go to the bathroom, whatever, you know. And so is this accurate, or is this something we should, as common people,
they're actually pretty accurate. I mean, you got to remember a couple of things. Though, and I actually had 3 conversations today in clinic about this. If you have any extra beats, like benign premature ventricular contractions, or PVCs, as we say it, or if you have a sinus arrhythmia, that is not a pathological rhythm. Neither one of those are pathologic. However, they can trick these machines. So you got to be a little careful, especially with like the finger monitors. I used to have a lot of extra beats after a car wreck. So the monitor would show on me, heart rate would go 70, 90, 140, 20. And so it's looking for a regular rhythm, but because you're having these extra beats or you have a sinus arrhythmia, it tricks the machine. So the machine just guesses. So always have to take. So if you ever get, I usually tell my patients, like the ones today, I say, if someone's getting a squirrely number for your heart rate, have them check it manually. Put it on your wrist or your neck, count to 6, how many beats you have in 6 seconds, multiply by 10. And that gives you your heart rate. But the machine, but the devices are actually pretty good. I'm amazed at how many people I have that come to me where their Apple Watch has detected atrial fibrillation. And, that actually, atrial fibrillation is a major cause of stroke. So there are a lot of people who go to the hospital and don't find out about their AFib until they have the stroke.
And you hear about the stroke and heart, this whole part of the heart health awareness.
Absolutely.
We forget about strokes, not just heart attack, but stroke.
You can have brain attack.
Right, yeah, exactly. Brain attack is what they call it, another name for it. Right. And that's not that can be deadly, and it can cause paralysis and sometimes...
But I think a lot more people are scared of stroke than they are of heart attack.
So, because it just hits you.
And it can debilitate you.
Yeah.
And especially too, the types of strokes that you get with atrial fibrillation are kind of the worst kind. They don't kill you, but they can debilitate you.
But the watch isn't going to detect that.
Oh, the watches can. No, they can.
So that's what you're getting into.
They'll get an alarm. Sometimes I give most of my patients my cell phone number, and they'll text me. I tell them, don't call me. I don't answer my phone. But if you text me, I'll get a text, here's my rhythm, and say, hey, this is saying AFib. So, we'll get them in the next day or the following day.
How do you get, what watches do this? Or is there something in your app that can show you?
There's a couple things. The more advanced Apple Watches have that feature. But more importantly, there's another device called a Cardia device that actually, if you don't want to spend the money on an Apple Watch, the Cardia device is actually great. It's FDA cleared. It's it's probably about an inch wide and maybe 3 inches long, and it syncs with your phone. And you see a commercial and you put 2 fingers on it, and it'll actually tell you if you're in normal rhythm or if there's a concern for AFib. So a lot of my patients that have had maybe a run of AFib after an operation, they don't necessarily want to be on a blood thinner forever. So I just say, hey, the Cardia device, I think before Christmas it was on sale for $64. With inflation, it's probably $300 now, but I don't know. It's probably sells $64.
No, I know what you're saying, but
these types of devices now are actually incredibly helpful to be able to
pick those up at a drugstore.
I think Amazon is where you can order that. You may be able to get it. They may be able to get that at a drugstore.
And they usually go for how much? Would you say probably?
Well, the Cardia is $64.
Okay, that's not bad. It's a good investment.
Exactly.
You go to the
Valentine's gift.
I go to my general doctor once a year to get EKG or kind of. Does that kind of determine that during that time?
That helps. But remember, a 12-lead EKG is 2 seconds of your day.
Yeah,
a lot of these people, it goes in and out. Now, one of the things to your point though about the device is a lot of people are actually picking up their sleep apnea on the device. So for all of our heart rates drop with sleep, but if you see low oxygen saturation, especially below 80, 88, 85. During the night, or you have heart rates that are dropping significantly lower than during the daytime, that may be a sign of sleep apnea.
They have a line on mine, and I'm just giving them a shout out here, but it's the Fitbit I just happen to have, and it shows a line, and it says if you're below the line, low, it's good, but above it's not so good. So you're looking for that. There was a couple times it spiked up for maybe I rolled on my side odd or weird, or I started snoring. I would assume in that case, or something that became an event.
So sleep is like the great frontier. We do not know enough about sleep.
Yeah.
But sleep apnea is incredibly common, and sleep apnea is there's 2 different types. There's central sleep apnea, then there's also obstructive sleep apnea. Central sleep apnea is where the brain doesn't send enough signals for you to breathe at night.
Oh, that's scary.
That's usually treated with oxygen. So, but obstructive sleep apnea is far more common. That's actually an obstruction where the soft tissue in the back of the throat will fall, and so it creates a physical barrier for airflow. It tends to be worse if you're on your back. That's why most people snore when they're on their back.
Makes sense.
Not all snoring is sleep apnea, but and you don't have to have snoring to have sleep apnea. But symptoms of
I didn't know that.
Right.
I always thought snoring was apnea.
It's
I
very
never
common.
Knew that.
So some of the generalizations in the past is you have to be fat to have sleep apnea. In general, it is generally weight related. However, I've got just as many tiny women that have the worst sleep apnea you've ever seen as I've had 450-pound patients who've been tested 20 times and they don't have any sleep apnea. And so it tends to be weight related. But symptoms of sleep apnea, certainly what I will tell you is when I hear a bed partner say, yes, they snore, pause, and just before I go to shake them to wake them up or elbow them, they go, and have, if you're doing that, you've got a 99% likelihood of having sleep apnea.
Wow. Okay. That's interesting.
But then,
so somebody hears that, they may want to check with their
exactly. And the nice thing now is we do for most people we do a home test. So we actually give you a device. You go home, you sleep with it in your own bed. You bring it back the next day, and we can tell you if you have sleep apnea. If you do, you can be treated. The treatment is actually so much better now than it used to be. Other symptoms of sleep apnea, though, before I go to the treatments, other symptoms: waking up with a headache, going to the bathroom more at nighttime can be a symptom. Definitely the pausing at night, fatigue during the day, shortness of breath during the day, feeling like you need to take a nap, falling asleep at the red light. Those are all kind of general symptoms. Sleep apnea is a major risk factor for AFib. So if you have atrial fibrillation, we always test you for sleep apnea. But the treatment is so much better than it used to be. You may have friends that say, yeah, I tried that sleep apnea treatment. It felt like hanging my head out the car window going 60, kind of like, like that. The new machine.
A lot of air being blown
exactly.
in. Is it like a CPAP, they call it a machine or something?
But now we have APAP, which is even better. So APAP is it's auto titrating. So it starts off with low pressure and then it gradually increases. And it only gives you the pressure that you need to keep your airway open. So some people who need higher pressures, though, they feel like it's difficult breathing against that pressure. So if they have a problem with that, then there's another modality that we can use called Bipap. And so it gives you the pressure that you need to breathe in, but then it drops the pressure significantly when you breathe out. So it makes it easier to breathe out. So a lot of people can, and you can get auto Bipap now. You can humidify the air. It's silent. I generally tell people that their bed partners just need to call them Maverick or Iceman. Don't call them Goose, but call them Maverick or Iceman. Say, hey, you're going to go shoot down some MiGs today? Come on, honey, you're my little fighter pilot. And the masks are so much better.
That's so funny. Yeah, because you think it's kind of gross. All that bacteria gets in there and stuff. You got to clean it or whatever.
I think some people get very claustrophobic by having something over their face.
Too,
But now they have some that come down and it just fits right up under the nose, so there's nothing in front of you. The nozzle's on the top of the head, so you can spin around in bed. And so the treatment options are huge. So what I generally tell people, if you couldn't tolerate CPAP in the past, give it another try. But now we actually have a surgical treatment for sleep apnea called Inspire, and one of our ENTs here in Columbus, Dr. Rhodes, is implanting these. And what it is, it's almost like a pacemaker device that helps open up that airway.
I'll be darned.
Actually, with the device, and then you have a remote control that you turn it on before you go to bed. It's fascinating.
That's incredible.
And it's especially for people who can't tolerate sleep apnea, other sleep apnea.
And this
treatments.
is an ear, nose, and throat specialist that would do that.
Correct.
Would actually put that in place.
Correct.
Going back to the AFib and trying to figure it out, because that has me wondering a couple things. You don't know an AFib. Could you detect it yourself? Do you know there's something weird going on? As much if you would maybe more of a cardiac where you feel the pressure, if you're running and you're feeling lightheaded or whatever.
So atrial fibrillation is fascinating. It is the most common irregular heart rhythm that we see. And so, we have people from age 17 all the way to 99 that have this, and everyone in between. And if you start talking about AFib in a group, you will find out that a huge percentage of people around you have either had it or currently have it. Some people have just postoperative AFib, so it's very common to happen with anesthesia, and that's usually a short-term type of thing. You can have longer-term types of AFib. Some people feel it, some people don't. The patients that I feel best about are the ones that say, "Yep, 802." This morning, 8:02, I went into it. And so in those patients, we can try to get them converted quickly because when we know when it happened, but a lot of people don't feel it. And so in those patients, we rely on some other, monitoring modalities and that type of thing. But the treatment is so much better than it used to be. We have medications to try to suppress it. Certainly, we usually put people on blood thinners depending on what their risk score is. The blood thinners are so much better than just the old Coumadin that we used to have.
So don't eat 3 times a week. sardines, you know, omega-3s, and take an omega-3 fish tablet every day. Is that enough to thin the blood, or
No.
Okay.
No. You know, I had a patient one time that said, you know, I heard alcohol thins the blood. I'm just going to go drink.
Yeah, right.
And he later had a stroke. But you know, but that's, and I did tell him I told you so. But
That's your told you so moment.
That's why I told you so.
You won't
moment.
say that unless it's
exactly.
You have to come back and re-educate
but the new blood thinners are so much better than just the old Coumadin days and things like that. But you don't have to be relegated to blood thinners now forever. We have other things. There's a Watchman device that can be implanted by our electrophysiology partners who come down from Emory in particular, Dr. DeLurgio and Dr. Patel. It's a device that goes into that little pocket, which is the source of the vast majority of strokes with AFib. And those people, right now it's FDA approved for people who have had GI bleeding, who can't tolerate blood thinners. But now they're actually doing this study to see if maybe you can just do it in everybody. And anybody that doesn't want to be on a blood thinner, because, you know, certainly, you know, you and I, we're at ages where blood thinner is probably not a big deal, but if we're highly active, if I'm going to go, you know, hunting, you know, that kind of thing, or, you know, have a risk of falling, you know, blood thinners put you at a high risk. Sure. So, you know, as you get older, it also becomes a higher risk as well.
Aspirin, 81 milligrams, you always hear that.
No, generally, so if you're a young person with very low risk factors, 325 of aspirin may be all you need. Okay. But for the vast majority of people who have any more than one risk factor, like blood pressure problems, that kind of thing, you're really more talking about like Eliquis, Xarelto, Pradaxa, Coumadin, those types of things. Gotcha. But now we have ablations. So now they can do an invasive test where they go in and they actually freeze the nerves that cause AFib. And, you know, the success rate on that is much, much better than it used to be. And so we've got patients that can go have that done and they have no more problems.
Wow. And then after all this, I wonder how many more problems people are going to be able to identify thanks to some of this awareness here today that we did. Dr. Hunter Champion, fantastico. I love it. And if you want to know more about cardiac health, we're going to be able to attach right here at the bottom of this podcast. Of course, you know, we can give you a link to find out more about some tips. We also want to, you know, if we even have you come back, Dylan, is there anything else, you know, we can find a way to get some information? I don't want to put you on the spot like you get 3,000 people calling you a day. Excuse me. Do not call him. Text him.
I only respond to text.
Him. He only responds to text.
I let my voice.
And you're not a millennial either. And you're not a millennial. Nope. I can't believe that.
But I have to have some control over the life, and just answering phones all the time is tough.
Going back to your point, you know, you got to be able to shut it off, meditate, and get in that space, which is really good. Dr. Champion, we can go on and on forever. And in fact, after this podcast, I'm going to probably, you know, I always ask you a couple of my own personal questions.
Absolutely.
I always do. Get a little extra advice here.
Nothing wrong with that. I can't believe that time went so fast.
It does. Well, we're over an hour, but with you, it could be 5 hours, and people would still love to tune in. But we do have to wrap it up. I hate to say that, so we can go meditate, take a few minutes out, get something to eat, and always think about moving. The smallest moving, as Dr. Champion says, keep active, do whatever you can. This is health and wellness. This is what we talk about all the time to make sure that you are in the proper step, the right beat in life. That's what it is. You can catch this episode at WRBL.com or any other post shows that we've had. We're talking about at WRBL.com. You can do that, or wherever you get your podcasts. Apple, Spotify, iHeart. Those are some places, too, to explore the Bob Jeswald Show and others here. And also on social media. We'll put this little clip here, Dr. Champion. It'll be situated, pinned at the top of my Bob Jeswald community page, Bob Jeswald Facebook and Twitter and Instagram. Follow us. We'll hopefully be able to give you some good advice coming up in the future. And as you always said, too, not only always be moving, but let's end with a nice little statement for heart health on the spot. Could you give me something?
Well, I think the key thing is listen to your body, talk to your healthcare providers, and get good advice.
There you go. Amen. See you next week. Thank you, Hunter.
Appreciate it.
Very good stuff.
Thank you.